Hi, I'm Peter Carlobos and I will be showing you how to perform endotracheal intubation. We have the following scenario. The anesthesiologist was called for an emergency intubation at the ICU for an obese COPD patient who recently self-intubated. Vital signs were the following: hypotensive with BP 80/40, bradycardic with HR of 50, RR of 20, with an O2 sat of 89%. Formulate your intubation process for this case. Instruments to be used are the following: suction, airway, oropharyngeal, nasopharyngeal, and laryngopharyngeal mask, laryngoscope, endotracheal tube of appropriate size, plaster, and stethoscope. We also have the mnemonic MAIDS, cardiac monitor and pulse oximeter, airway, IV fluids, drugs to be given, and suction. A CPAP machine is also needed. Make sure that the endotracheal tube to be used has no perforations by injecting 10 cc PNS into the cuff. For the procedure, first, perform airway assessment. Look externally, such as large incisors, dentures, large tongue, short neck, and obesity. Evaluate with 3:3:2 rule, the Malampati classification, obstruction, and neck mobility. Because the patient is obese, expect a potential difficult intubation and difficult mask ventilation. Then appropriately position the patient. For obese patients, place the patient in a ramped or semi-sitting position. This is to provide better view of the vocal cords. Pre-oxygenate the patient with 100% oxygen for 5 minutes with continuous positive airway pressure or CPAP with a PEEP of 10 cm H2O or with non-invasive ventilation. There should be chest expansions present and no leakage through the sealed mask. Simultaneously, perform the Celix maneuver by applying pressure on the cricoid cartilage with 10 newtons or approximately 1 kg. This is beneficial for a patient, especially that she is obese. Cricoid pressure should not be released until tube placement is confirmed. Give anesthetic drugs. Give succinylcholine as the neuromuscular blocker agent. Giving opioids, propofol, benzodiazepines, and volatile agents in obese patients are less preferred as they exaggerate obstructive sleep apnea and can worsen respiratory depression. Dose according to total body weight or ideal body weight based on lipid solubility. Once the patient has been fasciculated and relaxed, increase cricoid pressure to 30 newtons or approximately 3 kg and proceed to intubation. Due to obesity, video laryngoscopy is the method of choice. If not available or due to physician's choice, direct laryngoscopy can be used. Hold the laryngoscope with your left hand and insert it along the right side of the mouth, pushing the tongue to the left. Depth perception is difficult and therefore, structure should be identified as the blade advances past the tongue and epiglottis. Then, insert the tip of the blade behind the vallecula. Traction is then applied along the long axis of the handle, and the jaw and tongue are pulled forward and up off the rest of the face in order to give view of the vocal cords. The blade should not be levered on the teeth as a fulcrum. When there is massive aspiration, bleeding, or inability to identify the vocal cords, apply suction. Insert an endotracheal tube with stylet through the vocal folds. The tube should be inserted far enough to ensure that the cuff is far from the vocal cords. Then inject PNSS into the cuff. Remove the stylet, then attach the ventilator into the tracheal tube. Check for chest expansion. Check the position of the cuff by auscultating along the chest. There should be equal breath sounds in both lungs and no gurgling sounds. If one side is louder, deflate the cuff, withdraw the tube centimeter by centimeter, then auscultate again. Once correct positioning of the tube is confirmed, plaster and secure the tube using tape and remove cricoid pressure.